Afternoon, guys. My name is Christian, and today I will be talking about endemic mycosis. Just for the sake of time, so initially we're going to talk about like the general principles of fungal infections, but I think that we're kind of short on time, so I will kind of just go into mainly endemic mycosis, okay? So the content of today will be just a review and definition of basic concepts of mycology. We're going to go through cases of endemic mycosis, and after every case, we're going to review a clinical entity. So the learning points are identification of the morphology of pathogenic fungi. It's just like the main morphology. This class is not for microbiologists. Learning the definition of an invasive fungal infection and what that means, and the identification of the classical clinical syndrome seen in endemic mycosis. So just kind of an introduction to fungal organisms. So usually we hear these three main words, mold, yeast, and dimorphic fungi, but actually what they mean. So usually mold is a branching fungal organism, is usually multicellular. Yeast is like the superior picture that you can see is a unicellular organism, usually that divides by budding. The classical yeast is Candida albicans. The classical mold is Aspergillus. And you have your dimorphic fungi that are fungals that they can change in morphology based on the temperature. So at environmental temperature, like between 20 and 25 degrees Celsius, they can be seen as molds. And in the body, in 37 degrees Celsius, they can be seen as yeast. And mainly the topic of today is about dimorphic fungi. So apart from the classification based on morphology, we can also classify the fungal organisms by type of pathogens. So just by morphology, just the basics, as I told you already, yeast, molds, and dimorphic. So yeast, there is also another category called yeast-like. In this category, we have a PCP. The classical yeast is Candida, but also Cryptococcus and Saccharomyces are yeast. Rather than your classical molds, Aspergillus, for the ones that are going to do dermatology, all the dermatophytes, all your Tinnias are molds. Fusarium and Cladosporium, those are molds that you usually see in transplant patients. Rather than dimorphic fungi is all the endemic mycosis, and we will go there later. Regarding the pathogenic fungi, you have true pathogens and you have opportunistic pathogens. So the true pathogens can be divided by the type of infection or the location of the infection that they cause. So they could be subcutaneous, cutaneous, or invasive, or also called systemic. So in the cutaneous one, it's usually like the tinea, so microsporium that causes tinea capitis, trichophyton, and epidermophyton usually cause tinea corporis. Your subcutaneous one are usually the sporotrichs that causes sporotrichosis, and all the other subcutaneous mycosis that they go in a group called mycetomas, also actinomalura that causes a malura foot. Regarding systemic fungi, all in this group, true pathogens that can cause systemic infections are all the endemic mycosis, so plastomycosis, coccidio, and histoplasma. Regarding the opportunistic pathogens, we usually we see this more frequently in the hospital, so your classical pulmonary aspergillosis, your thrush, or your Candida esophagitis, and the PCP. So what means this? So this abbreviation is a term that you're going to see commonly in transplant and oncological patient notes. For those that are going to transplant centers, this means invasive fungal infection, but this is actually a misnomer because all the fungal infections are invasive. But usually what they mean with this term is a systemic, generalized, and specifically visceral, severe and life-threatening infection. So your Tinea cruris does not an invasive fungal infection, despite yes, it's invading the organism. When we say invasive fungal infections are visceral fungal infections. So as I say here, no superficial or local or benign infections. So just to do a general really quick overview of fungal testing. So these are like the usually 3 tests that we send here in the hospital. So beta-glucan, also called fungitel by the commercial name. So this test, the beta-glucan is just a part of the wall of the fungi. It's positive for multiple fungi. It's usually used for invasive fungal infections, guys. So if you think that the patient has a Candida esophagitis, you don't need to send this test. The other issue with this test, so the brand says that the positive levels is about 80, but actually we noticed that it has cross-reaction with multiple things, like, for example, sousing and other antibiotics. So actually, we don't have a specific value to say, like, this is positive or this is negative. So actually, this is not, like, the best marker, and this is usually usually used, like, for transplant patients or oncological patients. You should not be using this in your usual immunocompetent patient. The other thing that you need to know about this, so Cryptococcus, Blastomyces, and Mucor, they don't have beta-glucan. So you don't need to be, if you suspect these infections, this is totally useless. As I told you before, cross-reaction with multiple drugs, mainly the beta-lactams. Gustavo also was talking last week, also the filters of hemodialysis. So patients on hemodialysis, patients that go to cardiac surgery, like the filters that they use in the long heart machine has cellulose, so that also has beta-glucan, so it's useless in these patients. Regarding fungal culture, so this is a common thing that we see here. Like we say, like we suspect a fungal infection and we send fungal cultures in the blood. Guys, this is mainly for mold infections that can cause fungemia. So if you think that the patient has candidemia, you don't need to send a fungal blood culture. Fusariosis, this type of molds that cause fungemia, we don't see those patients here. We don't have transplant patients, so we should not be sending on a regular basis this specific blood culture for fungus. So in your regular blood culture, in your bacterial blood culture, you can get Candida and Cryptococcus, and those are the ones that we most commonly see here. PCP, usually pneumocystis, usually don't give you fungemia, so you don't need to be sending a fungal culture if you think that the patient has PCP. So now let's talk about endemic mycosis. So what are endemic mycosis? So these are thermally dimorphic fungi. As I told you, in the body, they exist as yeast, and in the environment, they exist as mold. So why are they called endemic? Because they are restricted to specific geographical regions and specific environments. So, for example, in one specific country, you can have multiple endemic mycosis depending of the weather and the type of soil that you have. So, something important and a general principle in this mycosis, the transmission is mainly by inhalation. Just Sporothrix is the only one that is mainly through a cutaneous inoculation, but most of these mycosis, the port of entry is the lung. There's no human-to-human transmission. The only way that you can get this from a human is through an organ transplant, usually the lungs. So for people that goes for lung transplant, for those that are going to do pulmonary and critical care, if you see a patient, for example, from Ohio, or the patient is coming from Central America, highest prevalence areas are Panama and Costa Rica. If you have a patient from Costa Rica and Panama, you need to do like a screening testing before doing lung transplant in this patient, if these patients are the donors. And as most infectious agents, so for this, despite they cause lung infections, they don't have any like specific like pathognomonic signs. So there is no radiological diagnosis. The other thing with this is like, for example, like for Aspergillus, you have like the halo sign in the CT scan. For mucormycosis, you have like the reverse halo sign. In endemic mycosis, we don't have any signs that can guide you in the CT scan. So just like, just to kind of repeat again the same concept of the dimorphic thing, just three like buzzwords that you need to know for the boards. So, and this also apply for like all the steps, whoever is like needs to take a step 3 right now. So each time that you hear, for example, a steering wheel, that's paracoxy, always. If you see a cigar form in a yeast, that always will be a sporotroph. So now let's talk about the geography of these diseases. So I usually divide these mycosis in two. So the ones that we can see here in the US and the ones that we can see outside of the US. So in the US, usually we can see blastomycosis and histoplasma. Those are like the classical in the Ohio and the Mississippi River regions. And they are kind of similar in pathophysiology too. And you have coccidioides that is usually in the western area of the US, so California and Arizona are the big ones here. And Sporotrix that is just in the tropical and subtropical areas of the US. So this can go from Florida up to Pennsylvania. So it's kind of all over the place, Sporotrix in the US. And you have the ones that you have outside of the US. So Paracocci is your classical South American disease. Thalaromycosis, this is just in Southeast Asia, and there's one just like recently discovered, Emonsia, that is that we thought initially that was just specific to South Africa, but now people start seeing cases in Canada. The things like 10 years ago, we didn't know how to recognize this, so now we have like a lot of post-mortem studies of transplant patients that die in Canada because of this disease, and we at that time we didn't know about this fungus, and we have a specific type of histoplasma in Africa. Also, outside of the US, you can see histoplasmosis, Sporotrix, and cocci. Histoplasmosis is kind of in all the continents. Sporotrix also in all the continents. Cocci, outside of the US, is restricted to Latin America. So this is just kind of a map. So as you can see, they are like literally all over the place. The continent with most endemic mycosis is the American continent. And of all these mycosis, the most common one is histoplasmosis worldwide. But as you can see, there are ones that are like specifically restricted to some areas, like for example, the thalaromycosis on the purple color, just like specific to Southeast Asia. We're going to talk about this later because actually it's a really like fun disease to know about. So in the US, as I told you, blastomyces and histoplasma in the Ohio and the Mississippi River area. Cocci is just like your southwestern and western US. And Paracocci is literally all Latin America, but mainly in the tropical and subtropical areas. So just I will be going through multiple cases. Each time that I give you a case, the three things that you need to think. And I think that this applies to all specialties in medicine, but it's especially important in ID. So the immune status of the host, the geographical location, and the type of exposure that this person has. So let's just do like the warm up case. So this is a 44-year-old female with history of leukemia, status post bone marrow transplant 3 years ago. She's in maintenance immunosuppression. She comes to you, you're the resident in the Hemon Clinic at Mount Sinai West due to a painless, non-pruritic skin rash for 10 days ago. She's from Northeast India, but she lives in the US since the transplant, specifically in California. In the review system, the only thing that she had positive is 1 day of subjective fevers. You measure the vital signs are normal. You see this rash. So for dermatology people, this is a vesicular umbilicated rash. So this looks like what? Okay, so this looks like molluscum. If you think like in something like, if maybe this is a kid, this is 100% molluscum. So the options here are herpes, varicella zoster, and molluscum, or histoplasmosis. So raise your hand who says herpes. It's painless, guys. So herpes, nobody herpes, varicella zoster, and molluscum. Most of the people should say molluscum, and histoplasmosis. Nobody histoplasma? Okay, good. So you discharge the patient with a diagnosis of molluscum contagion. 1 week later, she's admitted with hepato and splenomegaly and multi-organ failure. He dies after 1 week in the CICU on broad-spectrum antibiotic. the histoplasma antigen was negative in urine and blood. So now, what is the most likely diagnosis? Histoplasmosis, blastomycosis, cocci. Somebody say cocci. Blasto, okay, one blastomycosis here, and taloromycosis. Okay, good. So the correct answer here is taloromycosis. So just kind of an ID pair here. So there are lesions that they look like molluscum, but they can kill you. So the three big things are penicillium. The reason why I place this case is because this disease has 100% mortality. So if you don't get it within 1 week, and usually looks like a regular molluscum, if you don't get it in the first 2 weeks and start amphotericin, patient dies. The other things that you should know is cryptococcosis. So, but usually when you have skin findings, you will also have like a meningitis or pulmonary cryptococcus, and histoplasmosis that also presents with lump symptoms. You can have CNS and also skin. The kind of like the key in this case was that this patient was presented with subjective fevers. So guys, despite the patient doesn't have fever at the moment that you see him, if a patient is telling you specifically the immunocompromised, if they tell you that they have a fever, you need to pay attention to it. Okay. So case number 1, now going into endemic mycosis fully. So this is a 42-year-old male from Central America. He has AIDS. He's not in medications. We don't know the C4 from the past. He presents with 1 month of fevers, and he lost 6.8 kilos. He's coming with vital signs, Sears criteria. In the physical exam, you see a tongue ulcer. So this is actually a real picture, a case that is in Panama. So diffuse crackles. Patient comes with hepatosplenomegaly. You do the labs, CD405, pancytopenic, chest X-rays showing a diffuse reticular pattern. And in the blood smear, you see a monocyte, and you see a budding yeast. So guys, one thing that you need to know: you cannot make diagnosis of these things just like in the microscope. If somebody shows you a picture in the boards, forget the picture. Just focus in the history, because all the yeast, they look the same. At least you have like a specific stains, but literally they will not ask that in the. So all the information is in the case. Forget like the picture of the microbiology in the boards. So who says blasto? Pan blasto? Candida? Cocci? Histoplasmosis? Okay, good. So histoplasma is the correct answer. The clues here, so there is no blasto in Central America. Usually Candida is like free in the blood, should not be inside of any cells. Cocci is just restricted to the Western US, so this is not a cocci. So histoplasma. So all the endemic mycosis inside of the body are mainly budding yeast. So you cannot make the diagnosis, because the other ones can also seen as budding yeast. And the only way that you can actually differentiate them is if you see like the yeast like replicating and doing the stains in that stage. So histoplasmosis is the most common endemic mycosis in the US. It's caused by Histoplasma capsulatum. So I was telling you that there is a variant in Africa. The variety is Duboisi. Usually this histoplasma in Africa, so they don't give you any lung problems. It's just mainly skin and bone lesions, and we will see that later. So regarding risk factors and epidemiology, this is the things that will give you the case in real life and in the board. So a location of histoplasma, so will be the Mississippi and the Ohio River, and in all the Latin American area, you can be exposed to this. The highest prevalence areas are Panama, Venezuela, and Brazil. Regarding exposures, the main thing is the patient has any soil-related exposure. The classic vignette is like these guys that they went spelunking or going into caves. So this is the classic board question, but is any soil-related activity? And if this soil is contaminated by birds or bat pooping droppings, this is like this is like also a high risk for this. So for severe disease, what type of patients develop this? So patients with a cellular immunodeficiency, just as a general principle for mycosis, it's not humoral immunodeficiencies, it's cellular immunodeficiencies. So AIDS and human organ transplants. For HIV, is usually below 150, the CD4. And patients with COPD can get chronic pulmonary histoplasmosis. So just kind of to review like the cycles as all the things in ID. So usually you are in the specific location in a soil related or something with bat or bird droppings. You inhale the spores go to the macrophages in the lungs, and after that they disseminate to all the reticuloendothelial system. So that's the reason why you have like lymph nodes, skins, and bowel disease when you have disseminated disease. So regarding the clinical part, so we can divide the disease that is histoplasma producing immunocompetent and immunosuppressed host. So 99% of the patients are totally asymptomatic. So most likely all the people that live in a tropical or subtropical area or in the Ohio or Mississippi Valley has been exposed to this. So immunocompetent, so acute pulmonary, this looks exactly like flu. So you will have 2 weeks of really bad symptoms. After that, you will self-resolve. Most of the times we don't get these patients in the AD. So for immunosuppressed, these patients will have a chronic cavitary pneumonia. So usually you have necrosis and fibrosis. They cause cavitations, usually in the upper lobes. They can also cause a lymphadenopathy. So this looks exactly the same that tuberculosis. So another general principle of endemic mycosis in the lungs. So most of this disease will look as community-acquired pneumonia, and the chronic pulmonary disease will look as TB. This is more common in COPD and elderly males. And you have your progressive disseminated that we're going to talk later, and the CNS infection that is uncommon and can be isolated or part of the disseminated form. So regarding the progressive disseminated, so for example, this patient that I saw in Panama, he got the acute, so this is a progressive, like in 1-2 weeks, you die, it's super fast. Actually, I think that David Weininger presented a case like 2 weeks ago of a guy who was from Brazil, came here, AIDS, before was like 10, same findings, mucosa, lung, and pancytopenic. So usually, most common seen CD4 below 150 is rapidly fatal. So if you don't identify these cases in the first 2 weeks, usually patient dies. And you have your chronic one that you don't see in your like over immunosuppressed patients, is like older adults or patients with COPD and diabetes. So these patients will have exactly the same manifestations. The only difference is like the rate of the progression of the disease. So these patients can be alive like for months with this disease. So just kind of clinical findings in disseminated histoplasma. So fever, lung disease, and weight loss are the most common ones. Regarding skin findings, so histoplasma can present as multiple things, nodules, ulcers. So being honest, there is no pathognomonic skin findings in this. Just to show a picture of African histoplasmosis. So remember, this doesn't go to the lung. This is just skin and bone issues. It's rare. It's just present in Western Africa. For those that, I don't know if somebody's going to Montefiore, that there is a huge Western Africa population, so you can see this type of cases there. And the lesions are usually in the axial skeleton, the osteolytic lesion. So how do we do the diagnosis of histoplasmosis? So this is mainly a clinical diagnosis, so a clinical syndrome, an endemic area, and a specific exposure. Cultures can take up to 6 weeks, so it's the gold standard, but most likely patient will die if you don't diagnose that before. So the antigen detection is the best thing that we have here in the hospital. So urine is more sensitive than doing blood antigen. The only thing with this is like they can have cross-reaction with blastomycosis. So if the patient, if you're like in Cleveland or something like that, you need to be aware that blasto can also give you a positive histoplasma antigen. Serology also not useful because it can take 4 to 6 weeks, and if you have cellular immunodeficiency, you are not going to produce antibodies. The histopathology, so in the classic cases, they will see you like they will show you a bone marrow sample, but this is actually, the sensitivity is pretty low, so we cannot use it. And histoplasmin is an old test that we usually just use for experimental things. It's like the PPD of histoplasma, just like doing a skin reaction. Disseminated disease can give you pancytopenia and elevated LDH. Those are like the main ones. So just for treatment, so if the acute pulmonary histoplasma is mild and the symptoms last for less than 3 weeks, no treatment. If the patient has been more than 1 month with symptoms, you need to give the patient itraconazole. Chronic pulmonary itraconazole, progressive disseminated, we're usually going to see like the severe ones. Those are with amphotericin. And for prophylaxis, for those that are going to primary care and living in endemic areas, so CD4 below 150, patients should be in fluconazole. So let's go with the case 2. So this is a 39-year-old male without past medical history. He's your patient in the Ryan Center. He comes, he told you that he came with a chief complaint of acute hemoptysis, cough, and chills. You sent him to the ED. They did a chest X-ray here, primary lobe pneumonia, was treated with levofloxacin. He reports that he was cured. After that, 1 month later, he returns with a chief complaint of a verrucous, ulcerated lesion in his face and around his body. And also he's complaining of left thumb pain. They do a skin biopsy, broad-based pharyngitis. His only social history, he said that he went to Minnesota to hike 2 months ago. So which of the following is the most likely diagnosis in this case? So A, histo. Guys, the case can be repeated like the same, by the way. No, nobody said histo? Okay. Cocci? Sporo? Blasto? Okay, yes. So 3 hands for blasto. So blastomycosis is the correct answer. Well, and paracocci, that is not coming from Latin America. So blastomycosis is caused by blastomyces dermatitis. Just a fun fact, it's also called the Chicago disease because it used to be hyperendemic in that area. So risk factors of blastomycosis, so a location is the same, Ohio, Mississippi River. The only difference between histoplasma and this is it's not only soil-related activities, also grows in the water, so you can have a water exposures and get the blastomycosis. Severe disseminated is the same thing. Cellular immunodeficiencies can give you this, and pregnancy can also increase the risk for severe blastomycosis. The cycle exactly the same. That histoplasma goes to the lungs, goes to the macrophages, and after that disseminates to the body, to lymph, and also the blood. So let's go to the clinical part of blastomycosis. So this go like 50-50. So 50% will not have any disease, 50% will develop some type of symptom. The most common presentation is pulmonary, 90% of the cases. So acute pulmonary blastomycosis, literally the same that a community-acquired pneumonia. Fever, chills, you're going to see a consolidation, self-limitance. You may give him levofloxacin, and after 1 or 2 weeks of that, will feel better. The only thing is 15% of these cases go into ARDS, and obviously if you have that, you need to start thinking in other causes different to just like regular bacterial pneumonia. Chronic looks exactly like TB, so fever, night sweats, weight loss, you can have cavitations in the upper lobes. So chronic blastomycosis and chronic pulmonary histoplasmosis, they are kind of the same. The good thing is like most of these endemic mycosis, you can treat it with itraconazole. So if you're in the endemic region, looks like blasto, looks like histo, will be the same treatment. So 25 to 40% is disseminated. I know that these numbers, they don't correlate. So the thing is like more than 90% will present to a hospital with pulmonary symptoms, and maybe months later will develop this disseminated disease. So usually the condition appears after the pulmonary symptoms. The most common size skin is usually a verrucous lesions also can happen in the bone and the CNS. So your classic blastomycosis lesion is like a verrucous and ulcerating. So most of the time, it's just a localized area, but you can also have a disseminated blastomycosis, and can also mimic other things, like, for example, like skin cancers, like that one in the nose that is just a localized lesion. Same thing with the diagnosis of histoplasma, so clinical picture and endemic area. The good thing of blastomycosis is like within 1 week, you can get something in the culture. The fungal stain is less sensitive than the culture, so we usually don't do that. The antigen test saying that it's better in the urine, but there is a 70% cross reaction. So histology-wise, usually give you a granulomatous lesions. Antibodies for this disease are not useful, and we don't have it actually in our hospital. And the beta-glucan is totally useless. This fungus doesn't have any beta-glucan in its wall. So treatment-wise, just for symptomatic patients, so mild to moderate itraconazole, any severe endemic mycosis usually will need a liposomal amphotericin, and there is no prophylaxis for it. So case 3, this is a 28-year-old female from Los Angeles. She has a past medical history of diabetes type 1. She comes with fever, vomiting, altered mental status for 2 days. Family reports that she has not been herself in the last 3 weeks, and she's complaining of headache. Her physical, she has fever, she's tachy. Because of the altered mental status, they do an LP. The LP shows lymphocytosis and EOS. The MRI just shows inflammation, like generalized inflammation of the brain. You think that the patient has a fungal meningitis. Also, the interns check the whole patient, and he noticed that the patient has nodules in her lower extremities. So first, what's the diagnosis here? So why is cocci? Apart from LA. Okay, well, other thing, in the lumbar puncture, EOS. So guys, I think that the only fungal meningitis that can give you EOS is cocci. So as soon as you see EOS, if this is not parasites, it's this. So it's not sensitive, but it's pretty specific. So which of the following is the most appropriate treatment for a patient with a fungal meningitis? So this is a severe case. So caspofungin, fluconazole. This is actually a mix-up question. So, and I think that everybody fails. Amphotericin. Raise your hand who wants ampho? No ampho? Okay, one ampho. And hydroconazole. Okay, so most of the group here says that is option D. Chief? Any chief? Okay, so the correct answer is option B, fluconazole. So this is actually like the only fungal meningitis that you can just treat with fluconazole. Other important thing, guys, so the duration of this is years. And usually we don't take out the patients of the fluconazole. So let's say that you're a primary care physician and you see, oh, he got like 2 years of fluconazole, let's stop it. You cannot stop the medication because the mortality is so high that as soon as you stop that, the cocci may grow again. So you kind of leave the patients in suppression with that. So cocci is usually caused by Coccidioides similis or Posadaci. It's also called valley fever. The other special name that has is rheumatism, and this is important because it gives you a lot of musculoskeletal lesions. So this image is like classic in the boards. So for cocci risk factors, so location, western and southwestern U.S. exposure is usually DOS. For severe disease, so immunocellular deficiency, pregnancy. Guys, what country is this? Okay, good. So patients, Filipinos and patients with African descent are high risk for severe disease. We don't know exactly why. We think that is related to an immunodeficiency that they have, because they are not exposed to this organism in the Philippines. So cocci is the same port of entry is the lungs. So after the lungs has a blood dissemination go to the neutrophils, and after that has a blood dissemination. So clinical wise, so 60% will be totally asymptomatic. So the most common presentation is pulmonary, the same thing that the other ones. So acute looks like community acquired pneumonia. The only thing is like here, you're going to have skin findings and arthralgias, usually in the lower extremities. So usually people confuse this disease with autoimmune diseases. Guys, do you know what disease can give you these skin findings, lower extremity arthralgias, and like a consolidation with lymphadenopathy? Exactly. So sarcoidosis is one of the differential diagnoses here. And the chronic one looks exactly like TB, is a cavitary pneumonia, chest pain, hemoptysis. Risk factors is usually diabetes, and also can give you a diffuse miliary pattern. So for cocci, you can have also disseminated and reactivation. So risk factors are immunocompromised, being pregnant, or being from the Philippines or from Africa. Usual lesions are skin ulcers or abscesses, and also they can have meningitis. So the musculoskeletal and the lymphadenopathy can present in both, in the acute and in the disseminated one. So diagnosis, same thing, syndrome, location, and exposure. I know that I am being repetitive here, but this is like the main principles of infectious diseases. So regarding general tests, so these patients, they can have EOS in the blood. In the LP, usually is lymphoid predominant, but if you see EOS in the blood, they are pretty specific, so you should start thinking on that. Fungal test-wise, so the antibodies actually in this disease are really good. In week 3, 90% are positive, and they don't give any cross reactions. The antigen, we usually use it just for disseminated infections. Fungal culture, less than 8% of the samples actually grow, so we don't use fungal culture for this disease. So same thing, acute pulmonary, if it's uncomplicated, no treatment. The only difference between this one and the other ones is like usually itraconazole is not used here. Fluconazole is the drug of choice. So if the patient has asymptomatic and chronic cavitary pneumonia, the most important thing is to rule out a malignancy, because squamous cell carcinoma of the lung can give you like the same findings. Symptomatic chronic, you can give a fluconazole or itran for ICU patients have amphotericin. In findings, fluconazole, sorry. And for CNS, it's just fluconazole, guys. And remember, do not stop the fluconazole in these patients. For prophylaxis, so for HIV patients that live in California or in Arizona, you need to be checking the serology. It's usually every 6 months to 1 year to place the patient on prophylaxis if the serology changes. So for prophylaxis, yes. Yeah. Wait, if the patient has a positive serology. If the patient does not have positive serology, you don't need to place the patient on the prophylaxis. So case 4, this patient is a 56-year-old male from an unknown country. You recognize that he speaks Portuguese. So he comes with a history of months, because like the nurse told you that he coming with months of lesions in his mouth, in his gums, and also in the palate. When you saw him, he looks cachectic. They do a X-ray. He has like interstitial infiltrates. Where is the patient from? Angola. Somebody wants no Angola. Mozambique. All these countries are Portuguese speaking, by the way. Brazil. Okay, one Brazil. Portugal. Okay, so hands for Angola, hands for Mozambique, hands for Brazil. Okay, good. So yes, this patient is coming from Brazil. This is classic paracocci with all the mucosal lesions. So it's usually caused by paracocci brasiliensis. The other name of this disease is South American blastomycosis. So it's the same pathophysiology. You get the inhalation of the spores. After that, you get a dissemination to other tissues. Important things, 99% of this disease is just a granuloma. Like you do a chest x-ray, patient is coming from Brazil, you see a granuloma, you think that is TB, you do a quantiferon, the quantiferon comes back negative. What could be? So it could be this, could be histo. It's like, so most of the patients, they don't present anything. Usually for risk for severe diseases, immune cellular defects. So a location is just in Latin America, but the hyperendemic areas are usually the sylvatic areas in Brazil. Exposure-wise is soil, especially with farming activities. So risk factors for chronic disease, that is usually the more severe, is smoking and alcoholism. So immunocompetent is usually present in younger patients. The classic or chronic form is usually the one that we see from patients from 30 to 60 years old. And we have a mix of opportunistic diseases that is usually seen in patients with AIDS, with CD4 less than 200, and it's a mix of both diseases. So acute paracoxy, I'm just going to go fast through this. So it's just 30% of cases. Usually these patients present just with a mucosal painful ulcers, fever, weight loss, and usually they don't have lung disease. So the patient that we saw is like your classic paracoxy. There is the chronic or the adult form. Is more than 70% of the cases is usually seen in men because of the farming activities. It can be unifocal or multifocal. That means it has like multiple manifestations. And this is the only disease that actually has a criteria for severity of this group of diseases. So fever is rare. Usually patients present with productive cough, shortness of breath, chest pain, mucosal ulcers, and these ulcers, they tend to be destructive in the bone, so they can actually go, I have seen a couple of these, they go through the palate. You can see like the nose just from the roof of the mouth. So guys, for those that are going into hemon, what's the differential diagnosis of a lesion in the palate that can go like perforate? Squamous cells and well orphan. It's a heme a malignancy. So lymphoma. So the natural killer lymphoma usually presents with lesions in the medial line, and that's like the most important thing that you need to rule out in these patients. If this is not, let's say that this patient is from the U.S. and you see a lesion of the mouth, you know that this is not paracoxy, this is not leishmania, this is for sure most likely lymphoma. So we have a diagnostic criteria for this. So usually you need to be in the area. So there is a huge list of manifestations that need to be present for more than 4 weeks. And you need to rule out a TB, lymphoma, and leishmaniasis in these patients before you can actually make the diagnosis. The gold standard here is histopathology and fungal culture, usually grows pretty quickly. We don't have antibodies or antigen for this disease. CBC-wise, EOS can be present in acute paracoxy and neutrophilia in the chronic form. So treatment-wise, depends on the severity. So itraconazole or Bactrim we can also use. It's a cheaper option for these patients. And for severe disease, patient needs to get amphotericin. Guys, by the way, this medication, the itraconazole, costs like $400 the pill. So this is not like cheap med. There's no prophylaxis for HIV outcomes for patients in these cases. So case 5, we're already finishing. So it's a 34-year-old male from Miami. He comes with painless nodular ascending lesions in his left upper extremity for 4 weeks. He works as a laundryman. No history of soil-related trauma, no vegetations. So which of the following is the most likely source? So let me just show you the pictures first before. So he told you that initially he came with this ulcer, and after that he developed these like a lymphocutaneous lesions. So what's the most likely diagnosis? Okay, so sporotrichosis is the most likely diagnosis, but where is this patient getting sporotrichosis? So it's coming from the water of a beach in Miami. It's coming from a share that his son gave him from Puerto Rico. It's coming from the mother-in-law cat, or it's coming from the detergent in the laundry that he works? C? Raise your hand who says C. A? B? Okay, one B, one C. Okay, three Bs and two Cs. So the correct answer is from the cat. The second most common mode of transmission is with animals, and the cat is the most likely source in most of the patients. This is a real case. Yes, obviously the mother-in-law. So this also a case that I saw in Panama. This patient obviously not coming from Miami, but just kind of like the classic lesions. The reason why I say Miami is because it's a tropical area and it's endemic in Florida too. So usually the reason why you see this white thing is because the patient plays a cream, but actually it's just an ulcer. And that's the initial lesion that you see in this type of disease. And after that, you get like your classic cutaneous nodules in a lymphatic direction. So sporotrix is caused by a complex of multiple fungal organisms called sporotric chain-key complex. So has a worldwide distribution. It's usually in the subtropical and tropical areas. So the dark blue line in the top of the like pink one is like, so you can see like the distribution in the US is pretty wide. So actually we can kind of be like a little bit hyperbolic and say that New York may be included in this area. Regarding risk factors, so same thing, soil. The classic vignette is with gardening, but actually there is a question in your of cats. So you need to know because it's a classic question and it's the second most common way of transmission. Risk factor for pulmonary sporotrichosis or osteoarticular sporotrichosis is alcoholism, and for severe diseases, usually immunosuppression. So let's go faster in this part. So primary cutaneous can be divided in three. Lymph cutaneous, that is the one that we saw. You can have fixed cutaneous, that is just a single ulcer, and you can have disseminated, that is multiple ulcers without lymph node. Immunosuppressed one, you can have pulmonary or osteoarticular. So the lymphocutaneous one is the most common presentation, usually has a chancre or the initial ulcer that you get. It's usually painless, and you can have a secondary regional lymphadenopathies following a tract. This one is the disseminated skin lesion, so you're going to see like multiple chancres or multiple ulcers. It's usually painless too, and is associated with alcoholic patients. These patients will not have pulmonary or osteoarticular, it's just skin findings. And the fixed cutaneous ones is just a single ulcer. It's usually seen in children, and it's usually a localized lesion, and there's no lymphadenopathy associated with it. So, guys, for this disease, it's just history. You can do the culture, takes 8 days to grow, so it's pretty fast. Histopathology will be a suppurative granuloma, and we don't use blood tests for the diagnosis of this disease. So regarding treatments, also itraconazole for severe ones or pulmonary, we use amphotericin, and there is no prophylaxis for this disease. So we already talked about this. So this is mycosis, the one that looks like molluscum contagiosum. Southeast Asia is seeing HIV patients with C4 less than 100 transplant patients, and the risk is just being in an endemic area. Also, the transmission is mainly pulmonary. So molluscum-like lesions, so I don't know if this appears in the internal medicine boards or not. I don't know if, but it's like, I think that is a good differential diagnosis for the molluscum-like lesions. For sure, the ones that you can get in the boards is Cryptococcus and histoplasma with molluscum-like lesions. So usually, this patient will have hepatic involvement, lymphadenopathy, and like wasting symptoms. So the problem with this disease, we don't have any testing for it. The culture grows fast, like 7 to 10 days, but like literally we don't have any tests. of this disease because it's mainly in Southeast Asia. Problem with this disease, 100% mortality within 2 weeks. So if you don't recognize this disease, people usually die. There are like more than 200 cases reported here in the US. So we see those diseases here, especially in transplant cases. So just mention this, present in Africa, North America. Being honest, this is just mainly skin findings and low mortality. And that's all, guys. Thank you.
It's a great lecture, Christian, by the way. So you did a great summary of all the fungal infections, and you sort of like pointed out very important general principles of it. So my question is in regards to what's the role of, for example, when you have a patient that where the differential is broad, but the patient has skin lesions.
Yes.
What is the role of just either doing a scrap or a skin biopsy and sending that in the diagnosis of fungal infections?
Yes. So usually, so let's say that we have a patient that is coming, like an AIDS patient that is coming from Ohio, so with skin lesions. So this could be crypto, this could be histo, or this could be blastomycosis. So actually in these patients, you can get a sample from the skin, like a biopsy, or if the patient has any fluid, and you can culture that in a sabora culture, in a fungal culture. So you can actually grow and see the fungal organism. So there is actually an utility in getting that. The only thing is for histoplasma, the sensitivity is kind of low. Just kind of have that in mind that you may get it or you may not. But definitely, if you don't find a fungal organism in the lungs, and if you have skin lesions, the appropriate thing will be go for skin.
Yeah. Any questions? So the question from FAMA is that if we go with management instead of waiting for the culture results.
Yes. So the first thing will depend. So is this mild or moderate? Well, is this a mild to moderate or this is severe disease? If this is a severe disease and you have a clinical syndrome, the patient is coming from an endemic area and the patient is not responding to antibiotics because most of these patients will be at least 72 hours in antibiotics. As the patient that David had that was literally 3 days still spiking fevers, you need to place these patients in amphotericin. Just be aware that the only thing that is not like the best with amphotericin is cocci, that if you have a patient coming from the Western US with a disseminated infection that you think that is cocci, fluconazole.
He was spiking fevers for 10 days.
Okay, well, 10 days. Thank you, David.
We're very slow in diagnosing.
That was a very good case. I was also part of that the treatment team.
Yes, we worked together in the ICU.
We worked together in the ICU, yeah. I think Dr. Pfeffer was the one who actually thought about it. And I think the diagnosis was made with bone marrow.
Yes, with bone marrow.
Yeah. It's a very, very good
bone marrow
case. Yeah. I think for cases like this, it's good to share experiences that all of us have had with essentially failing a diagnosis. I had an experience that I actually shared with you, Christian, of a case that I was part of the treatment team in the ICU when the patient came after being on the floors for like almost 5-6 days. So this is a patient with CLL who was on some sort of treatment, not really severely immunosuppressed, but somehow immunosuppressed. Came in with pretty much a septic picture with lung manifestations, and also had skin lesions that looked like molluscus, some of them. Some of them were in the nose, some of them were in the rest of the body. The team that was taking care of this patient initially treated him with broad-spectrum antibiotics for sepsis instead of pneumonia, and then like almost less than 2 days after the patient was on broad-spectrum antibiotics, the blood cultures were growing yeasts. By the way, he also had a chemotherapy port. So everybody thought that was Candida, and including the ID consult service. So the patient was started on caspofungin for presumed candidemia. Speciation of yeast takes some time. So I think it was on the 4th day of the patient being on treatment, speciation came back positive for Cryptococcus. And as you know, echinocandins are not effective against Cryptococcus. So this patient rapidly decompensated, ended up in the ICU, and passed away from disseminated cryptococcosis. So it was a really important experience that I had in my life that led to reviewing this sort of thing and sort of like learning kind of like the issues with diagnosis in this type of patients. So any other questions that you guys have? Christian? Any questions, Sultan? I don't think many people.
I think that everybody.
So thank you, Christian. Great lecture.
Thanks, Christian.